So, a very good morning, guys. Today is a Sunday, and the next part of my prosthodontics lectures is, still incomplete. That is, I have told about CD. The next part about RPD and FPD is left. So, today I'm going to tell you about both FPD as well as your RPD in my next lecture. So, in my FPD, I want to tell you that prosthodontics is a very important subject for Neet, your Neet point of view, and you must stick to some certain points while studying the subject. Going through everything will not help you in getting good marks in Neet PG, but selective study and smart study will help you gain good marks. So, starting with FPD, telling about indications for FPD is short span edentulous arches, that is the arches which are not longer in length but shorter, and edentulous means there is no teeth, so shorter loss of teeth arches. Then presence of sound teeth that can offer sufficient support. Patient preference, mentally compromised and physically handicapped. Patients who can't maintain an RPD and FPD. Then in patients suffering from epilepsy and sudden burst of unconsciousness. For example, a patient who is undergoing epileptic treatment, he is having seizures. So in that kind of patient, we can't give an RPD because that requires your consciousness and in good state. But if we give an FPD, it's like a permanent natural tooth only, which will remain for long periods of time. Contraindications. The contraindications for FPD is your class of edenture the contraindications of FPD is we can't give FPD to patients who are who don't have sufficient amount of bone. There needs to be sufficient amount of bone for giving of FPD. And then we can't give FPD to patients who can't maintain enough of balance on chewing force, masticatory force on both sides. If there is imbalance of that, then there can be a problem. Then I'm going to tell you about classification of edentulous ridges, components of FPD, abutments, root configuration, crown root ratio, types of abutment, healthy or ideal abutment, cantilever, tilted abutment, extensively damaged abutments, pyre abutments. So retainer, what is a retainer? Retainer is a part of FPD in which unit abutment is attached to the retainer, remainder of the restoration, that becomes your complete veneer, complete porcelain or metal ceramic. Retainer is that part of FPD which unites the abutment to the remaining part of the restoration, remaining part of the teeth. Abutment is bound to the remaining part through the retainer. Retainer may be either in form of a porcelain, complete veneer and metal ceramic retainer. Intracoronal retainer is your inlays, onlays and pin ledge. Some important questions is choice of retainer on anterior teeth with favored clinical crowns is partial veneer 3/4 crown. For posterior abutment with acceptable crown root ratio, average crown length and normal aesthetic requirement, the choice of retainer is partial veneer crown. Next we come to the another question, choice of retainer for endodontically treated anterior tooth, that is your metal ceramic crown. Next is choice of retainer for posterior tilted abutment is 1/2 crown. Choice of retainer for lingually inclined mandibular molars is reverse 3/4 crown. Then choice of retainer for posterior abutment with short clinical crowns and unfavorable crown root ratio is complete veneer crown. Various surfaces of pontics. The various surfaces are saddle pontic, ridge lap pontic, flat back or interchangeable facing. The pontic which is having facing from both the sides which can be changed as along. Sanitary facings, reverse spin facings, posterior facing. Advantages of resin bonded FPD is these are fixed partial dentures which came cemented using into abutments using resin. This came in AIMS. Advantages of resin bonded FPD is they are non-invasive, conservative sensitive. Because of very minimal tooth preparation, they are conservative. This came in Comet K 2008. Types of resin bonded retainers. They are Rochet bridge, Maryland bridge, Virginia bridge. Factors influencing structural durability. Occlusal reduction. Gold alloys require 1.5 mm reduction in the functional cusp and 1 mm in the non-functional cusp. So there are functional and non-functional. Upper buccal, lower lingual is your functional cusp. That is bull, B-U-L-L. Upper buccal, lower lingual, functional cusp. Second, metal ceramic restorations require 1.5 to 2 mm in the functional cusp. That is your upper buccal, lower lingual, and 1 to 1.5 mm in the non-functional cusp. That came in Andhra Pradesh 2008. So this was all about FPD. In my next lecture, I am going to tell you about RPD.